All right, why don't we go ahead and get started. Good morning, everyone. Thank you for tuning in and welcome to VICA's 32nd Annual Business Forecast Conference and specifically to our healthcare panel. My name is Matthew Welsh. I am a VICA board member, Government Affairs Director at Amgen, and your moderator today. Before we get started, I do want to thank our track sponsors for both the housing and healthcare panels, California Lutheran University and Kaiser Permanente. And then let's also thank our panel sponsors, Cedars-Sinai Health System, Cosmos Health Solutions, and HealthNet. Now, the biographies for most of our panelists are already in the journal and online. So just in the interest of time, I'm going to make real quick, brief introductions so that we have more time for your questions at the end. So today, we're joined by Dr. Nolan Chang, Regional Medical Director of Business Management for Southern California Permanente Medical Group. Dr. Kenneth Kim, founder of Cosmos Health Solutions. Martha Santana-Chin, Government Programs Officer at HealthNet. And Dr. Jeff Smith, Executive Vice President and Chief Operating Officer for Cedars-Sinai Health System. I'm very excited to be joined by such an impressive panel, so why don't we go ahead and dive right in. Hospitals across the country have stepped up to care for patients during the COVID-19 pandemic. As COVID-19 patients remain the focus of care, patients with other illnesses, injuries, or needs who must be seen are avoiding hospitals at all costs. So what has this pandemic taught us about the challenges and opportunities for how quality healthcare can still be provided without an in-person visit? To get things started, I'd like to go around to each of you and give each panelist a couple of minutes to make an opening statement and introduce themselves and then talk about the question I just asked. And then what we'll do is go around and ask each panelist a separate specific question. So, and then also at the end, we'll open it up for Q&A from the audience. So let's begin with you, Dr. Chang. What has this pandemic taught us about the challenges and opportunities for how quality healthcare can still be provided without an in-person visit?
Thank you, Matt. So it definitely has taught us a lot, but what really has been a really consistent thing throughout of it is our mission really still stays the same. Our goal is really to deliver high quality, affordable care to our patients, really in a value-driven fashion. And so the environment might have changed and the tools that we need to use to be able to connect with our patients have changed. And so it's really understanding where we need to meet our patients at. At the beginning of this year, we really had a focus on consumerism, sustainability, and affordability, and that really has carried us through this year. Before the pandemic hit, as an organization, we had made great investments in virtual care, different tools, e-visits, chats, video visits, and we didn't expect that it would take off in this fashion. Really, COVID's been a tremendous accelerator, and we've been really happy to be able to lean in and help our patients in that way. And so recognizing that our patients are deferring elective care, that they're more fearful and not wanting to come in, we've had to really understand what we have to do as an organization. We shifted in Southern California, we were about 37% virtual before COVID really hit, to exceeding 80%, in some cases 90% virtual when we're really in the heat of things. That was fantastic because we wanted to maintain that relationship with our patients. But as an integrated healthcare delivery system, our other real interest was, well, how do we begin to understand the impact of this? What can we really get out of an e-visit or a chat? What can we get out of a video visit? How are we ensuring that it's really meeting the quality standards and allowing us to take care of not only our patients, but also the communities that we serve? So we've had to be really, really flexible because we've had to really walk that fine line of balancing the surge that we're experiencing in the inpatient setting with COVID, but also making sure that we're taking care of all of our patients, those with chronic diseases that were afraid to come in. How could we leverage the other modalities to really connect with our patients, address their chronic disease needs, whether it be diabetes and hypertension or hyperlipidemia? So really it has forced us to be very facile during this period of time, leverage the tools that we have, refine the tools that we have, reach out to our patients, understand what their needs are and how they're valuing these things. So it's just been a time of great acceleration, but really it's really forced us to focus on what our core mission is and how we execute on that in this new world.
Okay, thank you. Dr. Kim?
Hi, I come from a more private setting background. I'm a physician with an allergy practice in the Long Beach area for the last 20 years. And and I also work as a physician entrepreneur and have been involved in a number of businesses. The practice itself, treating allergy and asthma patients, was obviously immediately and greatly impacted in March with the shutdown, because a lot of our work clinically is actually seeing patients on a face-to-face basis. There was certain unique risk in an asthma practice where we have to do pulmonary function testing, which we were no longer able to do because of the risk of people, blowing out air and contaminating the air. And then the other aspect is a lot of patients have to come in for allergy shots. So the practice, unlike many private practices, took a really big hit for the first couple months while people were trying to readjust. We did shift more to a telemedicine perspective, and I would say where that was probably less than 1%. Over time, we basically have come to ways of actually accommodating, and obviously people with respiratory conditions just couldn't continue to stay away from the practice. So we have always stayed open, and we basically about 20% of our practice now is telemedicine, but we do have patients now coming in on a regular basis. We have we test our medical staff on a regular basis for coronavirus testing on a weekly basis. And if there is and at the same time, we also have a clinical research group. The clinical research group was primarily focused on doing allergy and asthma studies, and our group has been doing studies for over 20 years and run over 800 trials. And a lot of them has been also in the infectious disease flu area. So one thing that happened there is we ended up shifting our focus and working on right now a lot of COVID related research. So we're involved right now in evaluating some new COVID tests, actually in the antigen space. We're also doing tests and with treatment using monoclonal antibodies, and that's under clinical protocol. It's actually the same antibody regimen that President Trump received. And then we're also doing COVID prevention trials for people who are exposed in the family. They can actually get this monoclonal cocktail to see. And then finally, we're also involved in doing COVID vaccine trials. And then the last area where we ended up shifting is we ended up having people that employers that were coming to us and saying, hey, we need to be able to go back to work. And so we ended up starting a whole separate company, which is located in Tustin. And we service Southern California companies that require COVID testing in order for their workforce to come back. And we do a lot of work with actually studios, because they are, that's a situation where you have to have people come back on site. And so that has been a service that we've been intimately involved in and very involved in the testing arena. And we can get into that later, but the testing arena has been evolving very rapidly, and essentially every month there's a different set of tests that are becoming more optimal to use. And so that's sort of been our challenge.
Thanks. And why don't we move on to Martha? What has this pandemic taught us about the challenges and opportunities for how quality healthcare can still be provided without an in-person visit?
So thanks, Matthew, and all of you for joining. So just a little bit about HealthNet before I kind of dive into the opportunities and challenges, to give you a little bit of context. So HealthNet's a health plan that's been in California for well over 40 years. We serve 3 million members statewide. 2 million of our members are served through the Medi-Cal program. We serve Medicare, we serve commercially insured members as well. But that extensive experience in the Medi-Cal space has really been central to some of the work that we're taking on as a result of the pandemic and currently. And you know, one of the things that we've always taken great pride in is the fact that we're hyper-focused on some of the most vulnerable members of our community. We are an NCQA accredited health plan, and we're one of very few that also have a multicultural distinction, and we've had that since 2011. And really what that focuses on is organizations that have an acute focus and are actively engaged in improving culturally and linguistically appropriate services and reducing health disparities. And with that, you know, the other part about HealthNet is that we span the entire state. So everything from the rural areas to the urban areas. So we've seen quite a disparate set of challenges up and down the state. And, but there's also opportunities, right? So one of the things I couldn't agree with Dr. Chang more, one of the things that the pandemic has really done is accelerated work that we all had been collectively trying to move and advance for quite some time. And just the pandemic, the economy, tighter budgets, you know, it's placed a significant amount of pressure in us collectively really identifying innovative ways to address very, very basic needs for some of these individuals that we serve, those that are, you know, living in poverty, affected with chronic conditions, behavioral health issues, and quite frankly, are very concerned about just accessing care safely. And so this challenge has really fostered an environment and a need for significant cross-sector collaboration. And really this idea that demands that we all collectively in the healthcare space and with the wraparound supportive services that are out there, work together across that entire continuum, including the social service providers, to support the needs of our communities. And so that's definitely an opportunity, I think, that has come about as a result of that challenge. Technology is also something that we're very heavily leaning on to deliver better care, more timely care, more cost-effective care. And it's that need has only heightened, you know, tighter state budgets, tighter budgets, I think, across the system are calling for us to collectively rise and just be smarter about, you know, the way that resources are being allocated to support people's needs. And then, you know, the other thing is that while the crisis did provide that burning platform that has really fueled significant mobilization to deliver better care, more timely care, ultimately, you know, we at HealthNet very strongly believe that in order for us to fully take advantage of the situation, you know, we got to swiftly work to mobilize and make some pretty bold moves to really optimize the opportunity and reduce some of the health disparities that we've all been trying to reduce for such a long time and are now even further amplified by the pandemic. So, you know, it's no different than I think many of other sectors. We got to do things better, faster, cheaper, in a more innovative way, and with a lot less resource.
Better, faster, cheaper. I like it.
Yes.
And so, Dr. Smith, if you want to open your statement and then also talk about the challenges and opportunities.
Sure. At Cedars-Sinai, we've been, of course, really focused on continuing to be open and available to our patients, whether they need to be seen in person or they might be able to be seen virtually, either through a video visit or telephonically. I would say, in contrast to Dr. Chan and the Permanente medical group, we were much further behind, I think, in our implementation of televisits or video visits prior to the pandemic. We had a plan, a very methodical plan that we had planned to implement over a couple of years, that we implemented over a couple of weeks. And initially our concerns had been about the acceptance of video visits by patients, the acceptance by physicians. We had been concerned about the technology. We had been concerned about how we would get paid for visits. We're not an insurer, and so both the government payers as well as private insurers often didn't reimburse or had a lower reimbursement until the pandemic as well. And so all of these had been barriers that went away in an instant and that we had to figure out very quickly. And it's been largely successful. We did see a surge in visits that were done virtually initially. That's come down from, in some areas as high as 60%, down back to about 20%, where we think it's going to probably stay or seems to be leveling out for us. What we're really looking at now is assuring and establishing quality standards for those virtual visits. When is a virtual visit appropriate and when is it not appropriate? In addition to that, there's some services that just can't be provided virtually, including immunizations. And we're concerned right now as especially childhood immunizations are falling behind because in-person visits aren't happening. And you still occasionally need a procedure or an injection or an EKG or a X-ray or a lab test. And so making sure that we're coordinating that and establishing those quality standards, I think is going to be really important work going forward. In addition to that, we are really focused on patient satisfaction. And so we had well-established mechanisms for surveying our patients when they were either hospitalized or seen in the outpatient setting and making sure they had the optimal experience and had all the information that they needed. We're now doing a similar process with our patients who receive video visits to make sure that their experience, that they're getting the information that they need and are receiving the right care and the care that they choose to have. Sort of that consumerism aspect as well, optimizing the experience.
Oh, that's great. So what I'd like to do now is move on to asking each of you separate questions, but I do want to invite each of you to provide any sort of feedback or speak up if you have something you think you could add to the conversation. And for our audience, the best way for you to ask a question of our speakers is for you to click on the link below if you're using Zoom, and then you can type in a question that the speakers will see and can answer. Or if you want to stay on Pathable, please send your question through the chat box there, and then VICA staff will make sure that question gets to me. But why don't we start with you, Dr. Smith? Many patients have chosen to stay away from hospitals during the pandemic out of fear of contracting COVID-19. What have been some of the implications and ramifications as a result of this reluctance to visit a doctor? And how is Cedars-Sinai helping patients feel safer?
Yes, thank you very much for that question. I would say, there was a time early on in the pandemic where we intentionally kept patients away. And we were, all hospitals were ordered to forego or delay scheduled procedures or elective procedures. And so there was a delay in care, an intentional delay in care, as we made sure that we had have room for the patients and the COVID patients and the potential surge that we were expecting at that time. So the first thing is going back and making sure that we are getting those patients back on the schedule and getting them the procedures that they need that had been intentionally delayed. Now, at a tertiary medical center, sometimes when we say elective surgery, it's not elective at all. They're scheduled procedures rather than emergent procedures, but they can be cancer surgeries, they can be vascular surgeries, they can be heart surgeries, as well as joint replacements and other surgeries that are very, very significant. And it has an impact on people's lives and potentially on the course of the disease if they're delayed too long. So we did implement a procedure to prioritize those patients as we opened back up for scheduled procedures to get them in as quickly as possible. However, now we're in the next phase, the phase where, as you say, people may be choosing to avoid coming to the emergency room or seeing their physician over fears of exposure to COVID. And volumes are down. In some people are reporting that the hospitalizations for things even as far as heart attack and stroke that severe are down by as much as 40%. Now, there are some explanations for like trauma, for instance, if people are staying at home or not getting other contagious diseases other than COVID. Some of those things may come down, but probably not to this degree. And so we're very concerned that people are delaying necessary care, including cancer screenings, which is very important, as well as acute treatment. So as many hospitals and offices have, we've completely modified our operations. COVID patients are generally cared for in a different part of the hospital. As one of our panel members mentioned, we're screening all of our staff and anybody who enters our buildings for symptoms of COVID and for fever. Everyone on our campuses are masked. In our outpatient areas, we've really eliminated the need for a waiting room. We're using a virtual waiting room where you check in electronically, and we invite you to come in from your car directly to the exam room when we are ready for you. We have plexiglass up almost all over the place to help create those physical barriers as well. So we do believe that we can safely care for patients and protect our staff as well as protecting the patients. We really want to encourage people not to delay necessary medical care, which has the potential to create a second public health crisis from this delayed care. So thank you.
Absolutely. Martha, let's move to you. And this is a two-part question. How has HealthNet supported a significant ramp up in telehealth, particularly to underserved communities during COVID-19? And how has HealthNet remained connected to members, providers, and hospitals throughout the crisis?
Thank you for that question. So on the telehealth front, maybe I'll just take this opportunity to talk about a couple of different tracks that we've been running. So, you heard Nolan talk about the Kaiser experience, Jeff talk about the Cedars experience. I think in the underserved community, for Medi-Cal specifically, our provider groups, provider network, FQHCs, clinics, and they were even further behind, very little capability on the telehealth front. So what we very quickly did is when the pandemic hit in March, and then the lockdowns, happened subsequent to that, we very quickly recognized that our 2 million members, we needed to do something to really support them and support their needs. And, people were reluctant to go into the provider offices for very good reason. We knew that our hospitals were on the verge of potentially being overwhelmed. And so we had to find alternative ways to provide access. And so we set on this very, very ambitious plan to stand up a telehealth capability statewide to serve those 2 million members. And we targeted a couple months. And we had, quite a few barriers to overcome. As you can imagine, that was a pretty monumental task. So internally, we had a series of technical and operational issues and employee bandwidth issues. I mean, we had to deal with trying to get our workforce up and running and working remotely. And externally, the regulators, right? There was a lot of flexibility that had to come through in order for us to be able to provide these kind of services to our Medi-Cal population so quickly. And so, we had to work through that process to get the requisite approvals, understand the flexibility and the regulations that had been promulgated, et cetera. And so there was just a lot there to work through. But with all of that said, we really pushed through, knowing that we had to do it. Literally meant the difference between people being able to access care and not being able, or having to forego care. And I'm happy to report that we actually beat our 8-week timeline, and we stood up the capability in 7 weeks. And for any of you that have worked in healthcare for any period of time, you know that having to work with the regulators, having to work through the state, having to work within your own internal issues, that's pretty lightning speed. So we were pretty proud of the fact that, we were able to make that happen in partnership with our telehealth vendor, Babylon. And, the best part of all of this is that now, as we are assessing satisfaction for the members that are accessing that service, 98% of them are rating the service 4 or 5 out of 5 stars. And 96% of the time, members are able to get their visit addressed within 30 minutes from the time they ask for it. In Medi-Cal, that, you know, that's a definite win. You know, we're super proud of that. And then the other thing is that members have, you know, 25% of the members would have gone to an emergency room had it not been for this capability. So that's another, you know, real result, delivering real value for our members. But, you know, at the same time, you know, standing up a telehealth vendor solution is only one part of the equation. Ultimately, our goal is to make sure that our delivery system has the strength to be able to provide this kind of service for the most vulnerable among our population in a more sustainable way. And so on a parallel path, what we ended up doing is really focusing on supporting our provider partners and ramp up telehealth services within the practices to really make sure that we were maintaining continuity of care for the members that we were serving. And so we very quickly awarded 138 grants totaling $13.4 million to support the establishment and expansion of telehealth services among California providers. And, you know, that's the largest cash grant that any plan has really committed to telehealth specifically in California. Very, very proud of that. Many of the grants went to independent provider practices, rural health centers, community clinics, native health centers, and the like. And all of these providers, I mean, just keep in mind, these are smaller businesses that had significant financial strain when all the shuts down happened. I mean, some of them went to like 20% of capacity, right? And they had a payroll, they had, you know, employees and providers to care for. So this was really something that allowed them to get to a place where they're able to deliver care effectively. And, you know, many of them reported that at one point, 80% of their visit volume was via telehealth. Now it's similar to what Jeff reported, around the 60% mark. You know, it's the balance, so it's still both. But, you know, they've all stepped up and partnered with us on that. And at the beginning of this entire process, you know, one of the very interesting things is that at least 20% of the grantees had absolutely no capability whatsoever around telehealth at all. And those that did had not deployed any of it, right? Their workflows weren't set up to really administer telehealth visits. Everything revolved around the physical face-to-face visit. So it was, you know, on their part, it was a big, heavy lift as well. And so, you know, we really feel like this was a very important part of the work that we had to do to stabilize access to care for the Medi-Cal population and provide, you know, very cost-effective and high quality care, and, you know, given the restricted set of circumstances that we were under.
Hey, Martha,
Yep.
what percentage of your visits now are telehealth then in your clinics?
At the peak, they were reporting about 80. Now, what we're hearing more and more, it's in around the 60% range. In some markets, it's, you know, at 50. It really does depend on what's been happening in the community. You know, some communities have been a little more restrictive in terms of opening up and just people feeling comfortable, and some have been less. So it's hovering in that ballpark.
And has patient volume stayed steady? It's just that now it's 60% telehealth?
Yeah.
Is the volume stayed steady?
It's on the physical health side, it's been pretty steady. You know, where we have seen a significant pickup is on the mental health side. So, you know, as we did with primary care, there was also effort on the behavioral health side of our business to really support the needs of the community. And we've seen that volume to skyrocket. I mean, everything that you hear today about, you know, what people are having to deal with, and just, you know, it's good. The stigma around accessing mental health seems to be, you know, on the downward trend. And behavioral health providers have also embraced telehealth, which is, you know, phenomenal. That's something I think for a long time we've been wanting to see happen.
But overall volumes have stayed steady though, even though they've switched now to telehealth.
On the
overall?
physical health side, yeah, on the physical health side, yes. And on the behavioral health side, it has picked up. Yeah. So, you know, just the last thing I'll say about this is, you know, the money that we really contributed, when you think about just the differences in variability and infrastructure up and down the state, it's pretty massive, the disparities, right? So in some areas, it was really just about, hey, you know, the practices need more laptops, cell phones, software, et cetera. In other parts of the state, it was around, they don't even have wireless access or internet connectivity. And, you know, they needed a lot of technical assistance to get up and running. But, you know, all of this was really made possible by the fact that we worked very closely with Governor Newsom and his administration to really lay out a framework that enabled this. I mean, if you think about the regulations, if you think about, you know, the way that we had to repivot and allocate dollars, all of it was a true partnership there. And, you know, it's just been remarkable, right? I mean, we all, I think many of us can say we're proud of some of the things that we've done. This is one of those, you know, stood up and in the face of crisis, we're able to make some pretty remarkable things happen. And, you know, we're very optimistic about what telehealth is able to bring, especially in underserved communities, and are looking for, you know, expansion of that. And, you know, hopefully policies will continue to work in our favor to provide that kind of access.
That's great.
That's great, yeah. And Dr. Kim, I'm gonna stay on you for a little bit. I think this question's probably on everyone's mind. Can you give us an overview? Can you give us an overview of the progress for the development of the latest COVID treatments and the COVID vaccine?
Okay. So before I answer that, I was curious, can I ask a question? Because I'm, of course, as a provider, it's been really tough. But I'm not in the Medi-Cal space, but I've just shared with other providers, and I'm curious, Jeff, what in your network, what your private physician practices have felt. I'm just curious because we've had a 30-40% drop in volume, and a lot of it is, you know, people are reluctant to come in. We do have telehealth capability. There are challenges from the physician perspective because it is a little bit more unwieldy. There's always like different tech issues with each patient, and that these are sophisticated, educated patients. So I'm impressed that you can get this telehealth to be so successful in a more, you know, in a Medi-Cal population, because it's been challenging on the ground with they basically, you know, privately insured patients. And so the practices really suffered and had a really rough time of surviving. So anyway, I was just curious, before I jump into my question, Jeff, I was just curious what your experience has been with your physician providers. I'm just wondering whether the people I know just happen to be suffering and everyone else has been able to keep their volumes up and so on.
No, I think you're exactly right. And I think it's varied from provider to provider, specialty to specialty, and from practice to practice as well. And so for Cedars itself, we are, our physicians in our faculty group and in our medical network are very close to their previous volumes, with about overall, with about 20% of those visits being virtual visits now, and about 80% being in person. So volumes have come back relatively well. But it does vary highly by practice. And I would say, you know, we've had some physicians who are concerned about returning to practice as well. Some of them are elderly, and some of them have other of their own medical conditions. And so we've been looking at how we accommodate some of those physicians. And sometimes their full-time job might become doing those telephone or video visits. But we do know that it's affected physicians and hospitals, frankly, differently across our community. I think that many hospitals, especially the smaller hospitals, are suffering significantly because of decreased volumes that they're seeing. And so it really is putting a lot of pressure on the entire health system, individual physician practices, as well as hospitals and health systems.
The other place there's been pressure from a physician practice, and actually, Martha, maybe you can answer this, is I believe telehealth visits are reimbursed like significantly less. And so that's been a super challenge for those of us who are in private practice, because you're doing essentially the same amount of work for like 20-30% less reimbursement. And so and then you've got the issue of, you got to get the tech platform to work and so on. And then, since you can't do a full physical exam, it's not quite the same. So I think the justification has been that you can reimburse the physician less, but our overhead hasn't changed. So the practice part of our is really suffered. I mean, we've still, it's been a real challenge. But is that true that reimbursements are lower, or are you capitated, so it makes a difference to the physician?
Well, so in our model, we've got organizations that we capitate, right? And so what happened to a considerable part of our provider base is that they didn't see the cash flow drop the way providers that contract with other health plans, because we have a significant part of our base that we capitate. However, we do have in certain markets a high degree of direct contracts and fee for service, and we reimburse the same during this pandemic, during the period of emergency, the public health emergency rather, the same for a telehealth visit as we do for a face-to-face visit. In fact, the regulators require that of a number of products. So, one of the things that you may want to consider doing is just, looking at the regs from the Department of Managed Healthcare and just making sure that you understand the difference between payer or, product type, because there are some differences. But I think generally speaking, for us, we're paying the same for both during the public health emergency.
Okay. So I will shift over. So another hat I wear is I'm the founder of ARC Clinical Research, and we were doing many allergy and asthma studies, and that completely, like the bottom completely dropped out of that because of COVID. And I think the clinical research industry has in non-COVID areas have now started coming back in the last 2 or 3 months. But for 3 months, it literally every single clinical study, if it wasn't acutely dependent on patient care, went to a complete screeching halt. So that was a dramatic change. One of the things that we ended up doing on the ARC clinical research side is we ended up shifting and running, started doing a lot of trials in the COVID space. You asked the question of where are sort of the latest updates on treatment and vaccines. And so at a high level, there's now one drug, remdesivir, that's been approved by the FDA. The WHO did publish something saying that there was no change in mortality, but there is some data that is what the approval is based on, that it does improve outcomes in sick patients. And the earlier you give the drug, the more likely it's going to have an effect. So that's approved. Then there is something called convalescent serum, where you collect serum from people that have already had the disease. That has some theoretical and potential that it could work. The issue there is it's hard to study, because if in fact it works, nobody really makes a lot of money from it. So there's not a really good funding source to study, but there are studies ongoing right now with pooling convalescent serum, and that might actually also be an alternative. And then a third big category is the monoclonal antibody space. And there are two sort of leading candidates right now that are doing this. One is Eli Lilly and one's Regeneron. And both of them have applied for EUA, emergency use authorization, for their drugs. Eli Lilly showed if you use the antibodies early, there's a 72% decrease in hospitalization. Regeneron showed about a 57% decrease in hospitalization and a decreased use of emergency room or doctor's visits. So the treatments look promising. The side effect profile right now is very safe. They're no different from placebo. They initially started out as IV infusions because, I mean, the drug development for this monoclonal antibody story is also just like an amazing story from a clinical trial development perspective, because literally we took a new virus and over a period of months identified monoclonal antibody candidates that were highly specific against the protein surfaces, and then had to go through the whole safety process in animals and get some signal in animals to make sure that you can go into humans. So and then it came to the clinical trial sites, where it would take you typically maybe 6 weeks on a typical basis to get a site up and going. Contracts and site initiation, everything was being done virtually, and things were being done within 5 to 10 days. It was just total, and it's still like that. So it's been a really it's been a very interesting. I've never seen, and I've been doing clinical trials for 20 years, and I mean the speed and I don't want to say shortcuts, but let's just say the efficiencies that are being done as you implement these clinical trials are really remarkable. And typically you would run phase 1 trials, get the data, then do phase 2, sort of proof of concept. Phase 3, the trials are now adaptive in design. They are doing multiple data locks, like the Eli Lilly studies had 7 different data locks. Every time you lock the data, you unblind it, you look at it, and then you're adjusting study design, adjusting dose. And so one study became a phase 1, 2, and 3 all at once. And so it's just been fascinating to see in the antibody space. And then in the vaccine world, there are 49 vaccines that are in the clinic. Some of them are overseas. I would say there's 4 that are sort of far along that have gotten a lot of news coverage. The Moderna product, the AstraZeneca product, Pfizer, and Janssen, which just recently started. And they are in the process. Some of them are just in the process of completing their enrollment. The FDA has said that they will not approve a product unless there's over 50% effectiveness. Just as a matter of context, flu vaccines that we do seasonally will have effectiveness anywhere from 50 to 70%. So, those are not necessarily all, 100% protective either. And the endpoint for the vaccine trials isn't necessarily that you don't get the disease, but that it prevents you from getting a serious, or what I would call a moderate or severe COVID-19 case. And moderate severe will be defined by needing hospitalizations, obviously, death, ICU care, or significant issues with respect to your respiratory system, like oxygen desaturation, evidence of pneumonia. And so, the vaccine is going to be one tool, I feel, in this process of trying to get back to normal. But there's a lot of challenges with this whole vaccine arena as well, because something like 30-40% of the people don't want to take a vaccine because they're anti-vaccine. There's a lot of, even as we're enrolling these vaccine trials currently, there's a lot of, and also these treatment trials, there's also a lot of distrust. There's so much confusion out there of what treatments might be worthwhile, what's good. So when we get people calling that are like, is this going to work? Is it safe? And, the reality is some of this we don't know. I mean, obviously, these are very accelerated timelines. And I can go in more detail, but that's just like an overview. I would anticipate that we may get a vaccine approved maybe as early as first quarter. And then there's going to be the issues of manufacturing it, distributing it, and then a social issue of getting public acceptance of it, which is going to be a whole nother challenge. So that's just a high-level review.
Yeah, I definitely agree with the distrust. It's been interesting. Everyone I talk to, I feel nobody wants to be the first person to take it, but most people would be happy to be the second or third person to take it. And it's been interesting, again, touching back on the timeline, there's obviously been so much different language out there from either elected officials, company execs, scientists, based on, on what they think the timeline would be. And I think you're starting to see a lot of press around resetting people's expectations for these timelines. You're seeing a lot of stories run in the past even week. I read one yesterday. So, and I think you said first quarter, but $64,000 question, what do you think best bets on timeline?
I would say, you know, if we're lucky, we may get some a readout, and then it really needs to go through an FDA committee to look at the data. And there's two issues. The very beginning, even when you do a clinical trial with 30,000 people, you really don't, like when we rushed out the swine flu vaccine, and I forget what year that was, when Gerald Ford was president, we didn't see side effects until it went out to millions of people. And then there was an increased incidence of Guillain-Barré. And then that turned out to be, the swine flu ended up not being that virulent. So there was, in a way, some distrust to the medical community, because like, whoa, you're rolling out this emergency swine flu vaccine, and then the swine flu ended up not being that big of a deal. And then you had all these people with side effects with Guillain-Barré, and those side effects only occurred when you vaccinated millions of people. So, I mean, there is, you know, it's a complex issue, but timing wise, I would say earliest is going to be December, but I think more likely sometime in first quarter that you're going to get an approval, and then we have to start rolling it out. So I don't think it's going to be in the first. Then becomes who gets it first, and you know, clearly, first responders, people who are in, you know, healthcare workers, grocery workers, people that are actually in the front line should be getting it first. But you know how that also works, right? People who are wealthy, or people who have contacts, people, you know, the NBA teams, whatever. There's going to be a lot of political jockeying for access. Yeah, it's going to be. We've got our challenges ahead of us in the next year.
So I would just comment on vaccines as a healthcare provider. You know, we're developing plans for when the vaccines become available to address just some of those things that were outlined, helping answer those questions. It's really difficult to plan though when we don't know which vaccine we're going to get first. We don't, and each of them have different storage requirements as far as refrigeration or super cold freezers. So we're preparing for that, preparing the logistics for distribution and administration. We don't know how many we're going to get. Like I said, we're just now working through who should get it first as well. So lots of challenges in planning. And of course, we want to make sure that the people who are at most risk get it. So you're right, healthcare workers are in that first tier. But then in addition to that, it's going to be elderly and people with chronic conditions. But we also have information regarding healthcare equity and disparities. And we know that minority communities, Black and Latinx and other communities are at a higher risk and have worse outcomes. And so part of this does need to be prioritizing those groups who are most vulnerable.
Yeah, the two leading candidates, one of them, Moderna and Pfizer, are both RNA-based vaccines that require you to keep the vaccine at -70 before delivery. That creates a lot of challenges because most people don't have -70 freezers. You know, I mean, hospitals do, but that's an issue. You know, on the minority enrollment issue, I think one of the things we're on the clinical trial side, we're making a very active, concerted effort to actually recruit minority subjects into these vaccine trials and treatment trials, because the FDA, number one, is mandating it because they want to get experience in different ethnic groups, because there may be different amounts of efficacy in these minority groups or different side effects. And I spent my whole career doing ethno-bridging studies in clinical trials, and primarily in the Asians versus Caucasians, but there are differences that do occur. And so, you know, like with our current vaccine trial, we're partnering with large community organizations in the African American, Hispanic, and Asian American communities, and particularly because we need that data, and also those populations need access to this as well.
Yep, it's going to be interesting to see how this rolls out. I know from the biotech perspective, it's kind of an all hands on deck arena right now. But Dr. Chang, let's come back to you. So how has COVID-19 impacted consumers, and how can care be transformed to be safe, high quality, and affordable?
Thank you. That's a great question. And I think a lot of my colleagues really kind of spoke to it as well. Our generation of healthcare workers is really trying to focus and understand how we really evaluate social determinants of care and the impact of the patients that we're caring for. And so we've seen that, especially really early on. We had different groups that didn't have access to internet. And so we were trying to understand the impact, definitely from the ambulatory standpoint, but also from the inpatient, the acute care standpoint. We're really cognizant of when our patients were able to get in, the treatments that they were receiving, and subsequently we wanted to closely track the outcomes of those patients that have different factors at play. But when you talk about consumerism, COVID is something that has absolutely hit the entire world. There's no place that's been untouched. And for many of our members, we recognize that financially, many of them became unemployed, and that was a challenge. So our organization definitely wanted to pay attention to that, and how do we defer the elimination of the coverage and keep them on and allow them to shift from different business lines and still take care of them, because that was consistent with who we were. But really, we've seen, because of that financial fear, there's a lot more rationing going on. They're a lot more thoughtful with what they're doing with their dollars and understanding and wanting more out of them. As a result, we've seen also the fear, or especially early on, people didn't know much. And now we know a whole lot more than we did before, but was it even safe to come in? And that was really impacting whether they even wanted to receive care. And if they did, what venues and how they would want to go about doing that. As a result of that rationing, we would see they were deferring definitely primary care or more of their chronic disease or routine services. They would still come in for more of the specialty services, things that they felt were acute. But even some of those things, whether it be a hip replacement or a joint replacement, they were willing to put off until things were, quote unquote, a bit safer. But with that being said, we also saw a greater increase in willingness to be flexible. Jeff was able to talk about it. And I remember talking to our Cedars colleagues as we were, as two organizations, trying to map out what we're going to do in this virtual space. They were much more willing to adopt a virtual care. And it was interesting because you have populations that wanted that care and were willing to adopt it. But then we also, because we had some time on our hand, we'd even outreach to patients that weren't seeking care. And they were oftentimes surprised and really grateful for us outreaching in that manner. So definitely from a consumer standpoint, it really has accelerated things. There's a financial volatility that we have to be acutely aware of. But going forward, I think it really will change the way they expect to receive their care. And so I know things won't shift back all the way to the way they were. I think there will be a bump in more face-to-face visits as the vaccine deploys, like Kenneth was talking about. I think patients will be more comfortable coming in, but then I think it will settle back down as virtual care continues to expand in an accelerated fashion. So that'll be definitely interesting to see. Talking about how to safely receive care, I'll walk through that in a bit of phases early on and then kind of what we know now. What was really great early on was that all the healthcare organization, my colleagues on this call, we really didn't see boundaries and barriers. We really all leaned in and said, okay, great. This is a healthcare crisis that's in a generational event. What can we do to help each other out? What are we seeing? And so we were on many calls just like this, exchanging information. Now in Kaiser Permanente, one of the things that we really were proud to lean in on, we're supporting the LA Surge Hospital and the USNS Mercy. I think there was a lot of lack of knowledge at that standpoint. I remember in March and April, we were looking at the projections. And at one point, we were going to run out of ICU beds across Southern California in KP within 5 days, and then subsequently hospital beds within 10. So at that time, I was scrambling and saying, okay, great. If we're going to need to see patients in tents in our parking lots and we're doubling up all our beds where we're going to be having them in hallways, what would we need to do rather rapidly? So we were purchasing as much equipment as possible while the rest of the world was trying to do it because they were trying to work from home. And so that was absolutely a challenge that we had to be able to wrap our arms around. We had to partner in ways that we haven't had to in a very long time. So a lot of the impact that we were going to see wasn't just within our walls. It really was impacted by things like Governor Newsom. Some of the interventions that he made really did have a very, very profound impact. Otherwise, we would have been impacted in beyond our capacity. Yes, we overflowed our ICUs into our telemetry units, and so we were being very, very flexible. But we saw, interestingly, that it hit a subset of the population. You know, people look at us as a great country, and we absolutely are, and wondering how could this happen to us? Well, this is not the normal medicine that we've been delivering for the past 30, 40, 50 years. This is something uniquely different, where there was going to be a greater demand on ventilators and intensive care. The symptoms were very, very acute, and we had to quickly be able to pivot on that. We were looking for vents anywhere, and you heard that play out in the public. But as time went on, we knew more and more. Our approaches became more and more refined. So in the ambulatory setting, luckily, we in KP, we're looking at what does the medical office building of the future look like? So how do we encourage mobility? How do we do texting notifications to patients? That played out great in the setting. So patients were able to wait in their cars and not have to check in. They were able to check in at home, develop a QR code, and we were ready to see them. We could just text them and they could come in from their car. But we were able to really expand on different venues. So we didn't have as many face-to-face patients, which allowed us to really adhere to things like social distancing. And so as other patients were doing video visits, telephones, and the other telehealth modalities, it allowed us to look and understand how we needed to segment things rather quickly. What patients do we need to get in? One of the other things that really, even lately, we're refining is understanding how do we need to operate going forward. So Costco early on, or many stores early on, you saw them offer senior hours to allow their customers to come in a safe fashion. Historically, in our clinics, it was a mixed mash of people. It was, you might see a pediatric patient and then an elderly patient and then a young patient. But then we had to look at, do we segment our clinics? Do we really have certain hours or certain days for our elderly population, saying we're going to reduce the volumes because we know you're at the highest risk? How do we bring you in a safe fashion where you're confident in the care that you're receiving? And then do we expand into the evening hours and allow our parents that have young kids to come in and get vaccinations? I think all of us are doing things like drive-through testing. We partnered with Cal State Long Beach to set up a COVID testing sites where people could drive through. And we're trying to understand how we can really administer vaccines in this new world. And I know we're all really kind of struggling and trying to understand how we do that. So in that period of time, I think there's certain things we do know. There's still a lot we don't know. How long is this really going to last? What are the long-standing impacts? Like Jeff said, we're trying to understand how to prepare for the vaccinations. Where are we going to shift the people from? I mean, we have our staff doing things that we haven't had to do, screening at every single medical office building or hospital. That's deployed a lot of our resources because of the real dramatic surges in the inpatient settings, which weren't consistent across Southern California. We saw areas like Downey and the LA Basin get hit really hard, and then the Inland Empire. So we were dramatically trying to find ways to shift resources to where the patients were, but that also meant taking people out of places that they're comfortable. Many of our ambulatory physicians were really needing to go back into the hospital. And so it was all this really fine balancing act. But as a result of that, we've also had to partner with our colleagues, whether it be in facilities and IT. Like Martha said, we became very technologically dependent. And understanding consumerism, if you're doing a FaceTime visit with your buddy or your family member and the video freezes, it's not that big of a deal. But when it freezes when you're talking to your doctor, you're wondering, geez, if they can't even get the technology right, am I going to trust the vaccine from them? Am I going to trust what they're telling us? So that value proposition of consumerism got accelerated as well. For many of us, value really is outcomes over cost. But if the patient's got a confident experience in the physical setting or in the virtual setting, how does that make it easier for us to be able to deliver care? Kenneth talked a lot about that. So distrust of healthcare workers and the information that we're giving. How do we need to be able to bridge and prepare for that so that the patients are confident and we're meeting them where they're at? In healthcare, a lot of times I would say we would do studies. And a lot of the traditional studies would say, we're going to study males between the ages of 18 and 35, and they have all these conditions, and we're going to introduce this variable, and we're going to determine the outcome, and then we extrapolate that across patients. Typically, when you come in for a visit, we ask you fixed questions. Tell me about your past medical history. What medications are you on, and what are you allergic to? How do we shift that to other questions? Well, tell me about what you're doing for work. Who lives at home with you? Who prepares your meals? So it really is helping us to accelerate that. But in the care delivery part of it, we have to understand the support structures. Many people join Kaiser Permanente because we're a one-stop shop. You can come into a clinic, see your doctor, get your labs, pick up your medications, get an imaging study if you have to. Well, what does that really look like in a virtual setting now? And so if you're able to do a virtual visit, is it annoying all of a sudden if you have to go in to get your medications, or if it's not convenient for you to get your lab drawn? So how do we really shore up deliveries of medications to homes? So what does that virtual integrated care delivery system look like? And so we're having a lot of those really broad conversations, recognizing that our patients really want to receive care in different ways. One of the things that we've really leveraged in Kaiser Permanente is we have different patient advisory councils that give us this information, and we're looking really to them to drive a lot of the care delivery, more so than we ever have. For the past 50, 60, 70 years, we've pretty much known how we need to deliver care, especially when it comes to acute care settings. We have hospitals, we have clinics, we have skilled nursing facilities. And so if we have a certain population, we know what we need to build. But now we're going from an era where we know the solution and we know how to execute on it to really an era of exploration. What is it that the patients want? How do we do it in a cost-effective, quality, value-driven manner? So that really is a shift for our organization, really to meet our patients where they're at, instead of having them come to us because we're the healthcare delivery workers, we're the physicians, we know best, really to meeting our patients in the middle. And so I think it's a really good thing. We've always talked about putting the patient at the center, and more so than ever, that's going to be a really highlight of the upcoming years. And we're really looking forward to answering the call, and really meeting the needs of our communities and the nation when they need us.
Yeah, it's interesting. You talk about a lot of the different trends and whether or not they'll continue in a post-COVID world. And to be honest, I'm curious to see how it works out in and outside of healthcare. Do people go back to an office? Do they stick to telehealth? And it's funny, you mentioned being on Zooms and everyone having to adapt to the technology. And it's funny because I keep putting myself on mute while you guys answer so no one has to listen to my dogs bark. So yes, I know how that goes.
Yeah, definitely dogs barking is a norm and it's completely acceptable
Exactly.
now, whereas it wasn't in the past.
We all have to deal with it.
Shorts, right now, nobody would know.
Exactly. So I think now we can move on to questions from the audience. I do have some that have come in, and I just want to remind anyone in the audience, go ahead and feel free to submit them through the chat box. And now I think we can kind of open this up, and whoever wants to answer, go ahead and call out. The first one I have, it's how is the flu season going to impact COVID and hospital capacity as we move into the winter?
So I guess I can speak to that a little bit. So first of all, get your flu shot. That's the number one thing that you can do to protect yourself and your family and the community. So it will be very interesting this year. As we look at the Southern Hemisphere, we're seeing that they're not having a severe flu season. And fortunately, some of the things that we do to protect ourselves from COVID protect us from getting the flu as well. It also is a respiratory virus. So wearing masks and being distanced will help prevent the spread of the flu too. It will be particularly complicated because the symptoms of the flu and the symptoms of COVID are almost identical as they present these flu-like illnesses. So that too could affect decision-making in care. And so once again, the biggest thing that we're encouraging is for everyone to get a flu shot to help prevent one of the twin pandemic, if you will.
One thing that I'll say on the clinical trial side is there is rapid development behind the scenes to develop a point of care diagnostic test that has both flu and COVID on the same strip. So that may be out by this fall. I've heard many different people that are working on that, and that would be a really great diagnostic tool. So when people come into a provider, because the symptoms are essentially identical, the only way you're going to be you really need to do both because you don't know which one it's going to be.
Yeah, and I'll reinforce what Jeff is saying. Absolutely, everybody get your flu shot. This is not a fun time to be in the hospital, especially we continue to limit family members, their ability to visit. And so it's not a fun time to be in the hospital, and we don't want anybody to land there. But if you're going to go there, we will take the best care of you. And so a lot of the things that are also really limiting the spread of COVID are also going to impact the spread of flu. We are closely watching the Southern Hemisphere. And so, but we are doing everything that we can to prepare, because even if it's a mild bump on top of COVID, we are trying to prepare our inpatient facilities to be able to take on a dramatic surge. And we are reaching out to our partners and saying, hey, how collectively will we address the issues? So do everything we can right now to minimize the impact of it, but also as a healthcare delivery system, we're trying our best to prepare for it.
Gotcha. And that's really interesting. I had not heard anything about that dual flu and COVID test. Another question, opening up the audience, is the COVID-19 pandemic going to create demand for more of the smaller medical facilities to treat the elderly?
Yeah, I'll take a stab at that. I think it's going to change the way that our facilities have to operate. We're trying not to be too reactive. We do want to really keep this in the context of things, because when you're looking at facilities, oftentimes that might be a 40 or 50 year investment. So our pandemic is going to become more of a commonplace things as we're able to travel across the globe more rapidly, maybe. And so how do we keep the plexiglass in the storage room and pull it out when we need to? You know, I'm not sure if it's going to create smaller facilities per se. I think different facilities will be utilized in different fashions. As we go into telehealth, a lot of things might be able to occur at patients' homes. And I think what we're going to be doing in those buildings are really different. So historically, everything really was around that face-to-face visit. And so that was a time to catch up with our patients, see how they're doing, how their families are doing, what's new with them. Are they allergic to any new medications? Have they developed any new symptoms? How we address their care gaps? Do they need a colonoscopy, a pap smear, or those elements? But if you really take a step back and say, what needs to happen in that space? Do you need to give your history in the building? Probably not. Can you review your meds at home? Yeah, absolutely. Allergies, updating your medical history, what's going on with your family. A lot of those things really can happen at home. So what is it that we really need to do in those facilities? And so repurposing existing facilities is going to be important. I think our patients and our community's willingness to actually go out of their way to see us, that's to be determined. Do we need more small dots on the map where our patients are living, playing, and working? Maybe. I think a lot of the technological advancements will allow us to integrate into our patients' lives more, really reduce barriers to care. And I think you're going to see the facilities maybe play a smaller role. It's absolutely a venue of care, but I think you'll see it repurposed in different ways, but maybe smaller, but I'm not really sure on that yet.
Yeah, I would say that we've actually found some of our smaller clinics to be more problematic because we have less room to space people out. So the waiting room is smaller and the workspace for the staff is smaller. And so it creates even more difficulty creating the physical distance in those locations. Whereas in our larger locations, we can remove some of the chairs and have a smaller capacity in the waiting room, but we're still able to accommodate some people. So yeah, I think it waits to be seen.
Yeah, I mean, just one thing that I would add, just an additional perspective, just jumping off of something that Nolan said. One of the things that we've seen, I think this might also help explain, what we've seen in terms of the back to normal rates in terms of visits, right, on the Medi-Cal side versus some of this other, is that, for the low income communities, many of those communities are in health professional shortage areas, right? And so what happens is that, in a more affluent community, you might have one physician serving 500 people. In some of these other lower income communities, it's one physician serving 10,000 people. And so the idea of taking more to the home actually is a bridge to addressing some of the health disparities and access. I mean, if you think about just some of the very basic issues and barriers that some of these individuals have to face with transportation, distance, et cetera, et cetera. So, I mean, I would agree. It feels like moving more towards the home is going to be part of the way of the future. And, the facilities doesn't appear to be as much of an opportunity just on the surface.
That's interesting because our next question that came in was, is telehealth as effective as in person? And they also followed up, and just real quick, are you finding that people are comfortable with telehealth, or is there a certain reluctance that people have?
Yeah, I mean, I'll share some feedback. I think Jeff talked about this as well, pivoting to really assess satisfaction and quality through telehealth is really the next frontier. We've heard mixed feedback, right? In some communities, what has happened is people just love it. I mean, they rave about it. It's easy to use. They figure it out. They're able to connect really very, very relatively quickly. And so we do think it's gonna stick and it's here to stay. In other communities, and I think part of it is just the dynamics with what's happening with the demand, right? In other communities, part of what we're hearing is, listen, physicians are people, right? And they're being taxed much more heavily in some areas versus others. So I think one of the things that has happened is that whether it's connectivity issues in the rural North really affecting the quality of that connection with that individual, the lack of resources on the part of some of the communities, or, you know, providers that are overtaxed, right? In some parts of the state, people are much less satisfied with the quality of the telehealth than in others. But I think the other thing that's happening is that there is a recognition that there is also opportunity for us to, you know, pull resources and capacity from one part of the state to better serve other parts of the state. And so I think at some level, there'll be some equilibrium, you know, there. You know, it's mixed reviews, but for the most part, we're getting a lot of very good reviews, and there's pockets of dissatisfaction.
Yeah, I think one of the challenges is we just threw the technology out there really quickly and said, you know, learn how to use it and make it work. And so now we're in the process of going back, trying to improve the workflows within the software so that it's more seamless for both the patient as well as the physician or the nurse practitioner, and really make it a lot more seamless. We're also doing specific training for physicians and nurse practitioners on providing telehealth. How do you connect with a patient across the screen and build that rapport? So I think that too is kind of the next frontier for us.
Yeah, and we've undergone many of the same things. And so letting physicians know this is not the same thing as chatting with your buddies and catching up with your classmates and doing a virtual reunion. This is, how do we make this as professional as possible? What does etiquette look like? How do you convey empathy through the video versus being distracted and typing in a medical record? Because when you're in an exam room, that might be okay, but over video, it may not. I think organizationally, when we look at telehealth, trying to understand the quality it provides and the value it provides is interesting, because many people want to compare it to a face-to-face visit. It's not a face-to-face visit. It doesn't mean it doesn't add value, but it's different. And how do you, really make that a part of your toolkit? And so if there's a condition that historically would have taken 3 face-to-face visits, but now takes 3 face-to-face visits and 2 video visits, are you really adding value, or are you adding barriers? But if it's all of a sudden going from 3 face-to-face visits to 2 face-to-face visits and 2 video visits, maybe there is value if it's really bringing care downstream, improving outcomes. So we really do want to look at that holistically. From the patient satisfaction standpoint, I think it's really, really unique to the individual. So if you have somebody who's really afraid to come in but really wants care, they may be really happy with it. But on the flip side of it, if you have somebody that really wants to come in but isn't allowed to come in because there's not enough PPE or something, they're not going to be happy with it at all. So it really is, it depends on the audience, but for the most part, I think most of our patients have been grateful that we've been able to reach out to them. They've been willing to put up with some of the struggles around the video visit technology, recognizing that it's not just us in healthcare. This is something the entire world is experiencing. What happens after this when a lot of the restrictions are lifted, we'll see. I think hopefully this will give us a little bit of a head start to be able to refine a lot of these things like Jeff and Martha were talking about.
Good. And next, I'm actually going to combine 2 of the questions a little bit because they're somewhat similar. We've heard a lot of debate regarding the future of our healthcare system, especially on the presidential campaign trail. Now, they're asking what are some of the challenges and opportunities you anticipate as we begin to discuss how we deliver healthcare in the future. But I was also hoping each of you could talk a little bit about, besides COVID-19, what are some of the biggest challenges facing the healthcare industry?
So maybe I'll kick us off, and then because there's many challenges, right? I mean, we probably all can write a book about the challenges themselves, but just to focus on one is really around workforce, right? And the workforce shortage problem, as more people age and require, have more demand. And so, I mean, you know, that was challenging before the pandemic. It's heightened now. It's probably only going to continue. And so one of the things that we think is really critically important is to look at building skills for providers, leaders, right? The support staff that wrap themselves around the physicians that are providing important work, important care, and really removing barriers, right? So things like, you know, how might we reimagine healthcare to really make sure that we're creating career pathways for those in local communities, right? So are there partnerships with high schools, with community colleges, with the like, to really support and train people on tools and techniques like motivational interviewing, getting to really understand the needs of patients and members, and so that then when that individual is queued up to see a physician, the physician is very well versed in terms of what's really the driving and the root causes and the issues that are affecting the needs of that member. And so that we can really wrap around the needs of that member, that patient, in such a way so that once they get to the physician can really focus on treating their clinical needs, right? And so how can we expand workforce by developing the support systems around physicians is something that we think is really important. We've committed close to $4 million, I want to say, to workforce development issues, especially in low-income communities for that reason. But there's lots to do there, you know, around the talent pools themselves, getting, you know, people of color interested in providing care and becoming a physician at some point, and, you know, going back and serving their communities, looking at this as an opportunity for, you know, upward mobility of folks that may not have had other opportunities absent this. And then within the workforce themselves, really focusing on cultural competency and training for providers and their support staff to really, you know, do a much better job of connecting with the needs of the members. But workforce, you know, we would say is one of the more important issues that we're going to have to contend with.
And I'll chime in too. I think one of the biggest challenges of our generation of healthcare workers will really be around affordability. We've got the most expensive healthcare delivery system in the world that may not be providing the outcomes that our people really deserve. And so how do we really find ways to take cost out of the healthcare delivery system? And the other one that's a really big focus of ours is really healthcare disparities too. Everybody deserves the same great care and really the ability to achieve the same great outcomes. And so how, as a healthcare delivery system, do we become more flexible, really meeting our patients where they're at, understanding the challenges and recognizing it's important for us to get them all to the same place. To be able to achieve those things will mean that we have to partner in ways that we haven't historically done, that we're not used to and that we're not comfortable with, because a lot of the solutions to a lot of these problems fall outside of healthcare, and we're part of a much bigger society. And so I think that's going to be critical for us going forward, is how do we ask provocative questions? How do we engage in different ways? But also, how do we agree with the challenge that lies in front of us?
So I would say the most fundamental issue that we face in healthcare is how we continue to provide access broadly to the general population. And that really falls into the healthcare disparity that Nolan was discussing. You know, right now we have a system that is employer-based, and that'll probably have to, in some form, have to be stay in place because there's so many entrenched institutional groups like insurance companies, employers that want that, and so I don't think you necessarily need to get rid of the private insurance, but I think efforts like Obamacare and figuring out how are you going to extend that care to people who do lose their insurance, you know, is really critical. I was sitting on Joe Biden's healthcare policy committee, and what I really liked about the committee, there were a number of experts all over the country, and the focus was always on health equity, access, and actually there was a whole group on workforce development as well. But really, you know, we have a really big fundamental philosophic debate that this country is facing. Is it every man for themselves, or is healthcare a public good? And are we going to try and make that a public good? I think it's a big philosophic debate, and people are going to fall on opposite sides of this spectrum. But I firmly feel that if we don't stand up for broadening access, which means that you have to address pre-existing conditions, you have to allow, that's the reason why you spread risk out to healthy people. That's why healthy people need to pay something into the system, because you don't know if you're going to be the unlucky person that gets a cancer, and that's why we should be living. But so I think the fundamental challenge we face really is a big philosophic one of, as a society, how are we going to address healthcare to not base it simply on an employer-based system.
Jeff, any challenges you want to discuss?
No, I completely agree that the affordability and access for all members of our community is a critical task that we're going to have to face. Obviously, there's multiple different views as to how we get there, but I think that it's going to continue to be really important. Also, of course, we look at non-conventional and potential disruptors in healthcare. And we talk about Amazon, and we talk about Walmart or others who are entering in and taking parts of healthcare. And how do we maintain continuity for our patients? What role does that play? I think remains to be seen also. But nothing is constant in healthcare but change. And in some ways, I think this COVID crisis has accelerated our ability to change. And we have all learned that if we can focus our attention on something, we can move much faster. And things that typically would have taken place over years, we're accomplishing in days to weeks. And I think you've heard that from each of our presenters today.
Definitely. Thank you all. This has been wonderful. Unfortunately, that is all the time we have for this panel. Let's go ahead and thank our track sponsors, California Lutheran University and Kaiser Permanente, and then also our panel sponsors, Cedars-Sinai Health System, Cosmos Health Solutions, and HealthNet. I just want to give a real big thank you to my panelists here. Normally, we'd have a big round of applause. Virtually, that's obviously a little bit tougher. So again, just one big thank you from me for spending your morning with us today. Our keynote speaker will begin at 11:50 a.m. today. I encourage you all to visit our exhibitors so you can enter the raffle for your chance to win a number of prizes, including round-trip tickets on Southwest, a signed jersey from the LA Rams, and plenty of gift cards. Thanks, everyone. Take care.